remove secretions from the mouth, from the oropharynx, and from the nasopharynx. It is indicated in any infant who is unable to clear the secretions on his own. Look at this baby. He is a term baby but has poor muscle tone and is floppy. This baby might not be able to clear the secretion from his mouth. Hence, suctioning is indicated in this baby. For suctioning, we require suction catheter which has a thumb control. We use 5 to 6 French for a baby who is preterm and 8 French for a term baby. We require sterile gloves, distilled water or normal saline, and a suction machine. We shall now see the procedure of oropharyngeal suction. Wash the hands thoroughly and wear gloves. Now, attach appropriate size suction catheter to the suction tubing. Occlude the suction port with your thumb and set the negative pressure at 100 mm of mercury. Before suctioning, estimate the length of the catheter to be inserted by measuring the distance between the tip of the nose and the tip of the earlobe. Make sure that the catheter does not touch the skin during the measurement. Insert the catheter gently into the mouth until the measured distance is reached. Remember, the negative pressure should not be applied while inserting the catheter. Apply suction while taking out the catheter. Slowly rotate the catheter to ensure proper removal of the secretion. Limit the attempt to about 3 to 5 seconds. After suctioning the secretions from the mouth, do nasal suction. For this, insert the catheter gently upwards and backwards into the nares and apply suction. Then repeat on the other side. After suctioning, rinse the catheter and then discard it as per the universal guidelines. Always reposition the infant after you have performed oropharyngeal suction. Remember, avoid suctioning for 30 minutes to 1 hour after a feeding session, unless and until it is absolutely necessary to establish a patent airway. Suction only when it is required. Vigorous suctioning increases the risk of vagal response, which can lead to bradycardia and apnea. Never exceed a suction pressure of 100 mm of mercury. Oxygen source and a bag and mask should be available at the bedside during suctioning. Thank you.
Now, I'm going to turn our suction on. On this particular model, we have 80 to 120 is your medium suction. And we're going to leave it on continuous because once we get down, we want to go ahead and suction out. Go ahead and open up. There's a little sleeve here that you put your fingers under to open up, and that's your 1 inch margin here. Okay, and just crease your paper back to the side so it'll stay open. So 1 inch is contaminated where I can touch, the rest is not. Now, she's still doing fine. I do what I call a reality check. I got my saline ready to go. I've got my suction on. My surgical tube is here. So it looks like we're ready to go. 1 inch margin, I can put my finger in. I'm going to reach in and pick up my glove, step back off my field. I'm going to go ahead and put my hands in, and notice I keep my hands above my waist. Now, this one I'm going to touch here, and once I actually get ready to put my hand in, I'm going to abduct my thumb or hitchhike. And again, I step back off of my field so that I wouldn't contaminate anything. And sometimes, as you see, the gloves don't always go on the way you want them to, and you may have to sort your fingers out. Okay. Now, before I take and do anything else, again, I want to look and make sure I've got everything that I need. Now, the suction catheter, right now the whole suction catheter is sterile. Once you actually connect the surgical tubing to it and touch here, the pink part in back is not going to be sterile. So make sure you've got what you want. In just a minute, I'm going to put the lubricant over here on my field where I need it. But I want to look and make sure. So it looks like I got everything I need. My left hand is now contaminated. Okay, once I push this on, from the pink part back will be considered contaminated. Only from the clear plastic forward is sterile. Now I'm going to go ahead, because I may need some lubricant, and just put it on this part here, because that is not waterproof. Let's put it in your water first, just to check our suction, make sure we got it. Okay, and just lubricate a little bit, about an inch and a half. Now, we're going to go down, and she has told me that this is the better side than the area. Okay, here we go. Once I go down, there's a couple of things that happen. I have to go in and go out within 10 seconds. I do not put suction on until I start out. And when I start out, I do intermittent suction, and I pill roll, twist this back and forth. Okay, so here we go. Going down, 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 down. She's coughing, intermittent suctioning, and I'm twirling as I'm coming out. Okay, now, one of the things you want to take and be sure is keep this sterile. And then take this hand, if you don't have a monitor, to check her pulse. Because you want to make sure and know that she's fine. Because remember, that vagus nerve runs in the back of the throat. And if you stimulate the vagus nerve, it'll brady you down or asystole. So it drops your heart rate. So she looks like she's doing fine. Reassure her, put her oxygen back on if she has oxygen. Just keep her calm talking to her. Now, once she gets settled down, again, you want to suction out all the secretions that's left in here. Keep this sterile, because if she still sounds congested, you want to wait 1 minute and then go back in and suction her out again. Never suction more than 2 times. Okay? So she looks all right. She says she thinks she has a little bit more down there. Heart rate's good. I didn't have a pulse ox on her, so I have to check that a little bit later on. Okay? And some of the floors you work on may not have pulse oxes. So start relying on skin color, capillary refill, and how they're breathing and talking to you. Now, I'm going to go back down one more time. Again, my finger's off the suction. When I get all the way down, I'm going to pill roll and intermittent suction coming out. The thing to notice, too, is my hand never touches her nose. It stays close, but it doesn't touch her nose, because then I would contaminate my hand. So one more time, going in, feeding in, feeding in, feeding in. She's coughing, intermittent suction, pill rolling, coming out. I'm following it down. Again, roll it around your hand, keeping it sterile there. Talk to her, reassure her, check her pulse, look at her skin color, and get her to take slow, deep breaths. Sometimes you have to kind of talk them down and get them to relax. Because not only are we suctioning out their secretions, but we suction out their oxygen when we do this. Okay? So reassure them. Okay? She's sounding better. She thinks she's doing better as far as the secretions. Suction this all the way out. And then this would wrap around your hand. Pull your glove over top of it, and that way all the secretions are contained within it, okay? And it goes in the garbage. Any solutions left here goes in the commode, and then we throw this also in the garbage. Okay, all of this gets wrapped up and gets disposed of in the garbage also. Now, we can turn the suction off, make sure she's comfortable and doing okay. Do you need anything?
This video will demonstrate the safe administration of oxygen therapy. It will cover when and how to use different oxygen delivery devices, as well as how to prescribe oxygen for a patient. The treatment options include nasal cannulae, simple face masks, Venturi masks, and reservoir bag masks. As with any procedure, introduce yourself, correctly identify your patient, explain what you're going to do, and gain consent. If a patient is showing signs of respiratory distress, we can check how well they are oxygenating blood using a device called a pulse oximeter. This is a non-invasive way of measuring the SpO2, which is the oxygen saturation of arterial blood. The device is placed on the nail bed of the finger. The probe should be fitted securely, and any nail polish must be removed, as it can interfere with the reading. The monitor will then display the SpO2 as a percentage. SpO2 in healthy individuals should be between 94 and 100%. If a patient's SpO2 is below this level, this would indicate that they are hypoxic and need to be given oxygen. For most patients, when delivering oxygen therapy, we aim for a target saturation of between 94 and 98%. However, if a patient is thought to be at risk of type 2 respiratory failure, for example, those with COPD, we aim for a lower target saturation of between 88 and 92% whilst awaiting the results of arterial blood gas, or ABG. The oxygen delivery device and flow rate of oxygen can be changed to keep the SpO2 within this target range. We are going to begin by administering oxygen through nasal cannulae. This is recommended as being suitable for most patients with both type 1 and 2 respiratory failure. This is a hollow tube with 2 prongs, which insert into the nostrils. It can then be secured in place by taping it behind the ears. The other end of the tube is connected to some oxygen tubing, which then attaches to the oxygen cylinder. Normally, on a ward, the tubing can be attached to an oxygen tap on the wall. You can control the flow rate of oxygen going through the device using a flow meter. The design of these may vary between hospitals, but in general, the center of the ball or marker will tell you the flow rate in liters per minute. Nasal cannulae can deliver flow rates of between 2 and 6 liters per minute, but what we are really interested in is the FiO2, the fraction of oxygen inspired by the patient. For nasal cannulae, 2 to 6 liters per minute equates to an FiO2 of between 24 and 50%. Advantages of nasal cannulae are that they are comfortable and easily tolerated, often being preferred by patients compared to simple masks, as they can eat and speak easily. They are not rebreathing their own exhaled air, and the device is cheap. However, they can be easily dislodged, and the effectiveness is dependent on the pattern of breathing, since patients can still breathe room air through their mouth, altering their FiO2. An alternative to nasal cannulae is to use a simple face mask. This is less comfortable for the patient, but can deliver slightly higher concentrations of oxygen. The oxygen tubing is connected to the plastic port at the bottom of the mask. The open side ports allow air to mix and dilute the oxygen, as well as allowing carbon dioxide to leave. The mask can then be molded to fit over the patient's nose and mouth, and is secured by an elastic band at the back. The flow rate should be adjusted to between 5 and 10 liters per minute, and can be adjusted depending on the target saturations. However, it is difficult to know exactly how much oxygen is being delivered through a simple face mask. If a specific concentration of oxygen is to be delivered, or the patient continues to deteriorate, a Venturi mask can be used. These have special adapters which vary the diameter of flow in order to achieve a specific FiO2. They range from 24 and 60%. The adapters are different colors and display the required flow rate as well as the estimated FiO2. The oxygen is connected up in a similar way to the simple face mask, and the mask is then adjusted to fit on the patient's face. Venturi masks are used in situations where patients may have COPD or other risk factors for type 2 respiratory failure, and high concentrations of oxygen may need to be avoided. Aim for oxygen saturations of between 88 and 92%. A 28% Venturi mask at 4 liters per minute can be used whilst an ABG is obtained. If the patient continues to deteriorate or has arrived in a critical condition, a non-rebreathing mask is used to deliver high concentrations of oxygen to the patient. This has an attached reservoir bag and one-way valves which allow oxygen concentrations of 60 to 80% to be achieved. Once again, the oxygen is connected up and the flow rate is adjusted to between 12 and 15 liters per minute. The valve between the face mask and reservoir bag needs to be pressed in order to fill the bag up. It can then be adjusted to fit over the patient.
Going to be coming out and going to the patient. these two prongs get placed this direction, not the opposite direction. They're placed where the prongs are arched towards the back of the head of the patient. Each one is placed inside one of the nares, and this tubing, you can slide this to tighten or loosen this tubing. The tubing is placed, there's different ways you can put this on. I've seen it where it's placed like this and the tubing is put behind the patient's head and it's tightened in a way like this. One of the reasons you might need to do it that way is if there's a lot of deep pressure ulcer behind the ears of the patient. A more common way is if you place these in the nose, give yourself enough room to place this behind the patient's ears. And then you tighten it under the chin. What you want to make sure is that it's not too tight so that you're causing pressure behind the ears. That's one of the things you should check daily on your patients. And there are some where you can put, like, you can either wrap a bandage around to have some comfort so that it's not pressing against the ears, or your hospital may have something specifically for that, for comfort. So once it's on the patient, this end gets attached to the source of oxygen, which will be on the wall. This knob will turn the oxygen on or off. This isn't actually hooked up to the oxygen right now, but if you turn this to the right, there is a black ball in here, and this will rise. If you can see the numbers, it goes from 1 up to 15 on this flow meter. So as you turn this, you can adjust where this ball rises, and you need to set this according to the order you have as far as how much oxygen you're going to deliver to the patient. You'll need this wingnut type device. It looks like a tree. These are usually already on the flow meter. If not, you'll need to get one. You'll need that because that's how you'll attach the tubing of the oxygen. Make sure that's secure. Your wing nut is tight. And adjust the flow meter according to the order of how much oxygen you're going to deliver. Room air is approximately 21% oxygen. For every increment of 1 on this flow meter, you're adding approximately 3% of oxygen to room air. There is a range for each one, but an approximate is 3%. So for example, if you have this on 1 liter per minute, that will correspond to approximately 24 to 28% oxygen. That's not necessarily how much oxygen, though, the patient is breathing. That's only one of 3 components to determine that. The other 2 are how fast the patient is breathing and how deep the patient is breathing. So the rate of respirations, the depth of respirations, and the amount of oxygen you're delivering to the patient, all 3 of those are going to determine the range of inspired oxygen that the patient's actually getting. Now I'm going to show you a simple face mask. This is a simple face mask. It fits over the patient's nose and mouth, and the strap goes around the head. I'll show you that in a moment. This metal piece is what goes on the bridge of the nose, and you can tighten this to hold this mask on the patient's face. On the side of this mask are 2 open holes, and this is for air to go out as the patient exhales, and it's also as oxygen is flowing in to help push out air. This tubing is similar to the tubing for the nasal cannula, and it will also get hooked directly to the flow meter. One of the things that you want to check for before you put the oxygen on the patient, even for the nasal cannula, is you want to make sure that when you turn this flow meter on, that oxygen is actually being delivered through this flow meter and that something is not wrong with it. If there is something wrong with it, then you may have these on your unit, or respiratory therapy may have to come up and put a new one on. So this will get hooked up to your oxygen source the same way on the bottom of this adapter. Make sure it fits good. And again, you'll be turning this black knob to raise this black ball up depending on the order that you have on how much oxygen to deliver. For this type of oxygen delivery device, the simple face mask, this flow meter is going to be set anywhere between 8 and 12 liters per minute. This flow meter ranges where you could set it from 1 liter a minute up to 15 liters a minute. And again, you're going to need to set this between 8 and 12. That's pretty high. The reason that you need a high flow of oxygen through the simple face mask is that as the patient exhales, the exhaled air, part of it is going to be contained and held inside this face mask. Not all of it is going to go out through the ports. And that exhaled air contains a high amount of carbon dioxide. So you need a high flow of oxygen to help push out the carbon dioxide out through these ports so the patient isn't rebreathing carbon dioxide. This face mask can deliver between 35% and 65% oxygen, depending on the setting, between 8 and 12 liters per minute. So if you need to advance a patient to this type of oxygen delivery device, some other points to consider when you're putting on this simple face mask is that you can adjust the tightness of the mask by pulling on these straps. You want to make sure that you have a tight seal around the face so that the oxygen isn't escaping out through the side of this mask. A difference between the oxygen flow with the simple face mask and the nasal cannula is that with the nasal cannula, as a nurse, you will follow the order specifically as to the liter flow. The liter flow for nasal cannula can vary from 1 liter a minute up to 6 liters per minute on the flow meter. And you can set the flow meter exactly to what the order is. For the simple face mask, however, the order is in a percent oxygen, not in a specific liter flow. So the way that it works is that the physician or advanced practice nurse will order a certain percent oxygen to be delivered to the patient. And respiratory therapy will measure and adjust the liter flow between 8 and 12 liters per minute to ensure that the amount of oxygen being delivered is what's being ordered. And that concludes my demonstration of simple face mask. Now I'm going to talk to you about an oxygen delivery device that's called a partial rebreathing mask. As you can see, the mask part looks similar. It has a strap that goes around the patient's head, and it has the tubing that will hook up to the oxygen source. A couple of the main differences with this device versus this simple face mask is that there's this reservoir bag. This reservoir bag will remain partially inflated with a mixture of oxygen and carbon dioxide. Another difference is that as compared to the simple face mask, the side ports may have on these rubber flaps. The purpose for the rubber flaps is that when the patient breathes in, since these rubber flaps are on the outside, as the patient breathes in, the rubber flaps will adhere to the mask and won't allow room air to mix in with the mask. And the same when the patient breathes out, because they flap outward, some of the exhaled air, though, will be allowed to escape. So what that may do is by preventing room air from mixing in, it may ensure a more accurate delivery of the oxygen to the patient. On the inside of the mask, this opening where the oxygen is coming through, I want you to make note that there is no valve here whatsoever. For the partial rebreather mask, there is no valve. I'm going to show you another type of oxygen delivery device next, where there's a big difference, and one of the big differences is that that device will have a valve here. So the partial rebreather mask will not have a valve inside here. As far as how much oxygen can be delivered to the patient compared to the simple face mask, when the simple face mask, when the flow meter is set between 8 and 12 liters per minute, that will deliver between 35% and 65% oxygen. On the simple face mask, if you drop that flow leader less than 8 and especially less than 6 liters per minute, there is a very high risk of the patient rebreathing carbon dioxide that was exhaled, because there's not enough of a flow of oxygen pushing out the excess carbon dioxide that may accumulate inside this mask. So if need be, the patient could have an order for this type of a mask. So again, it would be placed on in a similar manner over the nose and mouth. Straps go behind the head, making sure they're not twist. You can pull on the sides to tighten. Make sure you have a tight fitting seal around the mask against the skin. You could squeeze this metal bar against the bridge of the nose for added security. And again, as with the other two devices, you're going to want to make sure that when your flow meter is on, that you actually do have oxygen. You can feel a flow of air coming out of here before you attach this to your oxygen source. So you want to make sure that's secure. And again, with this partial rebreathing mask, you're going to want to make sure that the flow meter is going to be set somewhere between 6 and 10. And similar to the simple face mask, respiratory therapy will measure how much oxygen is actually being delivered. And the respiratory therapist then may change that flow leader to accommodate to make sure that the proper amount of oxygen that is ordered is actually being delivered.